Thanks for being here. I understand that participation is mandatory. So, I'm going to talk today about the health status of Tennessee, and more specifically what we can do about it, with a talk that I'll subtitle, "How High is the Wall in Your Town?" And hopefully by the end of this 45 minutes or so, you'll have a better sense of the health status of our state, of our region. But I know some of you are not from Tennessee, about 40% or so, and some of you won't practice here, but I promise you what we're talking about here is relevant to the whole United States. It doesn't matter what state you're from, what state you're going to work in, or even whether you're going to work internationally. What we're going to talk about today, this idea of understanding health and what we can do about it, is pretty global. We'll start, though, with the realization that those of us fortunate enough to live in Tennessee live in a place of incredible natural beauty and a really remarkable culture and heritage. But we live in a state that suffers some pretty significant health challenges. And the purpose of this talk is to give you a sense of what those challenges are and how you can go about understanding them. Unless I hear otherwise from your faculty, I'm going to tell you you don't need to take notes. None of the details are as important as the concept. And I'm going to give you my business card at the end, which has the health rankings for Tennessee on the back of it, so you don't have to jot those down either. My goal today is to answer two questions, or to have you be able to answer two questions. All right? They're both what questions? Basically, what is the health status of Tennessee, and what can we do about it? What can we, all of us, do about it? To understand the health status of Tennessee, I'm going to take a step back and talk about the health status of our nation first. Okay? And when we talk about the health status of a nation, of a large group of people, what are some of the ways we use to evaluate that, to measure it? Obesity rate's a good one. What's sort of a general measure of health that we use if I was comparing the United States to Sierra Leone or some other country? Did I hear life expectancy? Yeah, that's right, life expectancy. It's the most basic fundamental measure of health. If you think about it, everything that goes into your life is reflected in life expectancy, isn't it? How old your mom is when she got pregnant, whether your mother used nicotine, alcohol, or other addictive substances during pregnancy, whether you were born in a safe environment where you kept warm the first 24 hours of life. Did you have adequate food and water? Did you grow up in a country free from war and famine and civil strife? Could you get an education? If you got ill or injured, could you get access to health care? Think about that. All of that times 300 million people is reflected in the life expectancy of our country today. It is the basic, most fundamental measure of health. And if we went out on the street of Johnson City or Nashville or Washington, D.C., and we asked the man on the street to tell us where the life expectancy in the United States is today, he or she, if it's a man on the street, I assume it's a he would tell us two things, right? First, he would say that life expectancy in the United States is probably the longest it's ever been, right? And here the man on the street would be correct. In 2008, life expectancy in the United States, a little over 78 years. So a baby born today is projected to live 78 years in the United States. It's the longest it's ever been. Quite remarkably, I don't know if you can see that in the back, 1900, from the time my grandparents were born until the time my youngest daughter was born, actually she was born in 1998, but you get the idea. Life expectancy in the United States went up by 30 years. Think about that for a second. In the course of a century, life expectancy, how long you, your colleagues, your children were expected to live, went up by 3 decades. So the man on the street would be right here that life expectancy in the United States is the longest it's ever been. The second thing the man on the street would tell us is that life expectancy in the United States is probably the longest in the world. He knows we're the wealthiest nation that has ever existed. We have a healthcare infrastructure unlike that anywhere in the world. We prepare our health professionals better than anyone else in the world. And here the man on the street would be wrong. In 2008, the United States ranked behind all of those countries and ranks 34th in the world. Okay, almost 3 dozen countries do better at this most basic fundamental measure of health than does the United States. almost 36 countries where a baby born today is projected to live a longer life than a baby born in the United States. Okay? And as disturbing as that is, if you look at all 50 states, starting at Hawaii with a life expectancy of almost 82, all the way down, to save you reading the whole list, there's Tennessee, fully 6.5 years less than the longest life expectancy achieved by any state in the nation. If we were to compare Tennessee to other countries, here are all the countries in the world ranked from 25th down to 75th. Tennessee would fall about here: Ecuador, Qatar, Bahrain, Sri Lanka, Croatia, Slovakia. Now, you can't really make that comparison because we collect data differently in different countries. But even if we added 1 year or 2 years to our life expectancy, we would find ourselves comparing ourselves to countries about which we normally don't think of comparing ourselves. This is looking at premature mortality. This is a little complicated, so I'm going to explain it to you. This is a line created by all 3,120 or so counties in America. Okay? It's years of productive life lost, basically a measure of premature mortality, early death. So the median county in America is here. The top 10% is here. I leave off the top 10 and the bottom 10 because the numbers get a little quirky, okay? But first of all, there's something interesting there, which is how what a wide range there is in the United States, right, between counties as far as their premature mortality. That's the 3,100 counties in North America and the United States. Here are the 95 counties in Tennessee. And what you can see is that our median is almost 25% worse than the national median, and 90% of our counties fall in the bottom half of the country. All right? So here is this basic measure of health, life expectancy, where the United States does remarkably poorly within the world, and within that, Tennessee doesn't do particularly well. Now, these are measures of death, right? There's other ways of measuring health besides death. You mentioned obesity, smoking rates, on infant mortality, high school graduation, all sorts of things you can measure. So every year, the United Health Foundation comes up with a ranking. They take 22 different measures, and they rank all 50 states. And what was Tennessee's ranking this year? 42nd, right. We were 42nd. 9th least healthy state in the nation. Now, that looks pretty bad, doesn't it? The answer to that is yes. If you get that on the exam, yes. That looks pretty bad. Actually, we're kind of pleased with that because in the last few years we've been 48, 48, 47, 46, 47, and 44. So 42 actually looks reasonably good. Those of you that wish can get your very own No More 42 pen when you're done today. And when people ask you why, you can tell them. Now, when we first started, it was No More 48, right? Had a No More 48 pin. This is a true story. It's a good Tennessee story. I wore it the first day, and someone said, well, you better not wear that into Lowe's. Turns out Jimmy Johnson, NASCAR driver, drives the number 48 Lowe's Chevrolet. People's natural assumption was, so this is not anything to do with Juan Carlos Montoya, who I understand is number 42. This is ranking for the state. Okay, it's not the number 42 that's so important here. It's what's behind it. Remember I said there are 22 different measures that go into this. All right, and here's what they are. Poor physical health days. Tennessee ranks 48th. How many times in the last month has your health interfered with what you want to accomplish? Violent crime. Tennessee ranks 48th, third worst in the nation. Obesity, 48th, third worst in the nation. The second leading preventable cause of death. Cancer death, the number 2 cause of death, 46th. Infant mortality, the chance of a baby dying in the first year of life, 46th. Preventable hospitalizations, 45th. Prenatal care, 45th. Cardiovascular, leading cause of death, 44. Premature death, 43rd. Smoking, the leading preventable cause of cancer, 41st. Cancer death, excuse me. And poor mental health days, 41st. Here we are halfway down the list of 22. And Tennessee is still in the bottom 10. All right? There's an additional 6 where we're in the bottom half, and 5 where Tennessee's in the top half, including, interestingly, immunization coverage, where we're the best state in the nation. Yes, everyone gets hung up on binge drinking and violent crime. Tell me the truth. Were you all paying it? That's what you were. Right. So the violent crime thing. We used to be our worst one. And I used to give that talk, and people would say, well, that's because of the folks out west, in Memphis and so on. So this is a true story. I was in Memphis giving this talk one time, and they said it was because all those folks in Nashville and the East. Binge drinking is how many times in the last month a male reports having 5 or more drinks in a single sitting, a woman 4 or more. But again, what's interesting about this is some of the things that you would think are associated with good health outcome, like primary care physicians, public health funding, and so on, Tennessee actually does reasonably well. So I started by posing 2 questions, what and what. Most of you now are asking a different question, right, which is why. Why should a baby born in Tennessee today be more likely to live a shorter and less healthy life than a baby born in most other states and in dozens of other countries? Why is a baby born in this state more likely to live a shorter and less healthy life than a baby born in most other states and in dozens of other countries? Why do we have health statistics in our state that are so much less than we could achieve? Why do we have health statistics in our state and our nation that are so much less than we could achieve? We're a nation that prides itself on being able to solve problems. We're a nation that exists because we are a nation that solves problems. Why is it that we have health statistics in our nation that are so much worse than we could achieve? And I say we could achieve it because other countries achieve it. I say Tennessee could achieve it because you saw on those lists there are other states that are actually healthier than Tennessee. Well, the reason, and this has been something I've been interested in for some time, the truth is most people are unaware. Most people really don't understand that the United States isn't the healthiest country in the world. Even when they see the statistics, many people will deny it and say, well, isn't it true that Cuba collects infant mortality rate different than the United States? Isn't it true? These numbers, I don't make them up. Okay? These come from legitimate, credible sources. We have to accept them for what they are. Most people are unaware. Problem is that even among those that are aware, most assume that these problems are either inevitable or unsolvable. And that's really what we want to talk about, right? The inevitable folks say, look, 70 is about all the human body is meant to get. We're a little bit beyond that. But the truth is, life expectancy of 78 is no more inevitable today than a life expectancy of 42 was when my grandparents were born. All right? I have in my office a book called the Virginia Health Bulletin from 100 years ago. These are the leading causes of death in Richmond, Virginia, which is as close as I can get to East Tennessee 100 years ago. Tuberculosis, by far and away the leading cause of death, followed by cancer, which we recognize today, but then whooping cough, typhoid, influenza, diphtheria, scarlet fever. All right? This made me go back and look at the leading causes of death in the United States as a whole 100 years ago, and here you see them. Now I'm going to take these same causes of death, the same scale, and update it by a century. All right? This is worth a lecture in and of itself to talk about this changing causes of death. But my point in putting it here is simply to say these things are not inevitable. All right? What we die from is not inevitable. Whether we live to 78 or 81 is not inevitable. It is probably inevitable that we will die, right? But how long we live and how healthy we live to that point is something that can change. The other issue is some people say, well, okay, it's not inevitable, but it is unsolvable. And this, of course, is not true. We know precisely what we can do. There was an article in the New England Journal of Medicine 2007 that looked at the factors that contribute to premature death, early death. If you're dying early, your life expectancy is shorter, right? So what are the factors that cause us to die young? Well, about a third of it's due to genetics. Okay, there's nothing we can do about that. There's no reason to believe that our genetics in Tennessee is fundamentally any different than it is anywhere else. Social circumstance we'll come back to in a little bit. Environmental exposures make sense to you. This leaves 2 wedges in the pie. Okay? One that's pretty small, one that's pretty large. Things that cause us to die young. And it comes as a surprise to people to learn that this one is health care. What this is saying is that if all Americans had access to the very best health care, which they do not, we would reduce our premature death rate by about 1/10. Now that's really important. And if we could reduce our premature death rate by 1/10, we'd be well advised to do it. And I feel very strongly that all Americans should have access to affordable health care. That is not a political statement. If I said how we should get there, that might be a political statement. Saying that we should have access to affordable health care is simply saying that I believe that what you're learning is something that has intrinsic value to people. It can change people's lives, and I can't rationalize a reason to say that some subsection of our population should have access to what you're learning and another group should not. But the point here is that health care, at least at this point, is a relatively small contributor to our premature mortality. So what's this big thing that's causing 40% of our early death in this country in general? Yeah, lifestyle, behavior, right? Behavior, things we do, all right? It's not rocket science. Some people are surprised at how large that impact is, but the fact that it's a major factor in causing us to die young is not a surprise to you. There was another article in the Journal of the American Medical Association where the Centers for Disease Control listed the top things that are causing us to die. Top behaviors. What's number one? That's right, smoking, causing about 1/6 of all deaths in the United States. What's number two? Yeah, factors related to diet and activity. Now the percentages drop off pretty quickly here. Alcohol about 3.5%. Microbial agents, infectious diseases, 3%. Remember, 100 years ago, that was 2/3 of the deaths or more. So these things are not inevitable. Toxic agents, secondhand smoke, environmental pollutants, 2%. Motor vehicles, self-explanatory, 1.8%. Firearms, self-explanatory, 1.1%. Sexual behavior as it leads to AIDS and other conditions, and illicit drug use. These are the things the Centers for Disease Control and Prevention says we're dying from. And if you look at this list as healthcare professionals in training, you should see two very important messages here. The first is that these problems can be solved. All right? If we had time, I know that each row of you could sit and spend the next 20 minutes and come up with 2, 3, 4, 5 evidence-based interventions that you know would make a difference for every single one of these. Look up there and ask yourself, is there anything on that list that you don't think you could make a recommendation that would reduce death from that thing? The second point is more subtle than the first, okay? But it's actually probably more important. And that is that these problems are more easily prevented than cured. Take a look at the list again. How many items up there could you go to the doctor, or could someone come to you as a pharmacist and say, give me the cure? Arguably only one, and that's infectious diseases, right? You can give antibiotics. Though I can tell you that death from infectious diseases went down dramatically in the pre-antibiotic and the pre-immunization era. It was really improvements in sanitation and water and so on, food safety. But the important message here is these problems can be solved. But what we're looking at is a failure of prevention, not necessarily a failure of our healthcare infrastructure. Okay? Now, these are the leading causes of death in the United States. Let's take a quick look at what we know about them in Tennessee. Okay? So we'll start with tobacco. This is, for those of you in the back, that's 1990 to 2010. The blue line is reductions in smoking in the United States. And you can see we've had a general trend down. There was a couple of a decade or so there where it stayed about flat, but it's been consistently coming down over time. Here's the state of Tennessee, also coming down, but trailing the nation by 5 to 7 years. Okay, so that today Tennessee is 41st in the nation with a rate of smoking, remember the #1 preventable cause of death in the United States, that's about 1/4 higher than the national rate. All right? So clearly smoking is an issue in Tennessee. Here's the 3,100 counties in America. Again, a very dramatic, steep slope. So the top 10% counties in America are way down here, and the bottom 10% are way up there. Here are the 95 counties of Tennessee, with about 75, 3/4 of our counties falling in the bottom half, the worst half for the nation. So clearly smoking is a major health issue in Tennessee. How about obesity? Well, you all know we're in the midst of an obesity epidemic. Have you all seen these maps before? You know, you should have. I'm actually contractually required as a dean of public health to include this in every lecture that I give. It wreaks havoc at Sunday school. Sorry. All right, so what we've got here is, for those of you that missed it, that's the United States, all 50 states. 1986, okay? The states that were white had no reported data in 1986. The light blue were under 10% obesity. The darker blue, 10 to 15% obesity, okay? So in 1986, there was not a single state that was over 15% obesity. So now we start the graph in motion. 1987, 1988. 1991, for the first time, we have states that are 15 to 20%. Tennessee joins that group in 1993, drops out briefly in 1994, comes back to stay in 1995. In 1997, for the first time, we have states that are 20 to 25%. Tennessee joins that group in 1999. In 2001, for the first time, Mississippi becomes the first state with more than 25% obesity. Tennessee joins that group in 2004. In 2005, for the first time, we have states with more than 30% obesity. Tennessee joins that group in 2007, stays there in 2008, and in 2010, for the first time, the last state with under 20% disappears. What you've just seen is a pretty classic epidemic map of an epidemic of obesity spreading throughout the United States, such that when the epidemic began, there was no state with more than 15%. Now there's no state with under 20%. If you look at Tennessee, there's something quite interesting here. This is 1990 to 2010 obesity in the United States. Here's Tennessee. And what's interesting is that from about 1990 to almost 2000, we were pretty close, and then we've begun to diverge since that point. And you can ask me later why that is, and I don't know. Tennessee currently is the third worst state in the nation with a rate of obesity. Remember the number 2 preventable cause of premature mortality. It's almost a quarter worse than the national rate. If you look at all 3,100 counties in America, again, not quite the linear, the straight line we've seen before. And there's Tennessee, such that 90% of our counties fall in the bottom half of the nation. So again, you know, I could probably stop the talk at this point and say, okay, guys, we got a problem with premature mortality in the United States. It's worse in Tennessee. We know the reasons. Those problems are addressable, but we haven't addressed them yet. And those problems seem to be worse in our state than in other states. And I could stop at that point. But if you're thoughtful, you're probably asking a pretty obvious question at this point, which is why? Why should we have higher smoking rates in Tennessee than in other states? Why should we have higher obesity rates? We can accept it, but if you really want to do something about it, you have to ask the question, why? And this is where we get into a new field. Here it was called social circumstance. We now talk about the social determinants of health. And it's the realization that our health isn't always about the things that we normally associate. It used to be, he's a 55-year-old white male. We would define people by who they were. Then we would add their behaviors. He's a 55-year-old white male with a 20-pack-year smoking history. All right? But now we've come to understand that there's a whole range of factors that impact people's health beyond the genetics and beyond their behavior, or it impacts their behavior. And these are what we call the social determinants: early life experience, the economy, race, ethnicity, community, housing, work, education, income. You look at that list and all of those things make sense to you, right? You can look at that list and say, yeah, I understand how each of them, as played out, could impact health in our community. But you may not appreciate how incredibly strong these relationships are. So I just want to show you 2 of them. I'll start with income. Now, if I asked you to take a list, a piece of paper, I'm not going to ask you. Maybe I will, but not now. Take a sheet of paper and write down on one side the least healthy countries in the world, and then on the other side write down the poorest countries in the world. And most likely you'd have many of the same countries, right? We instinctively understand that poverty and poor health go hand in hand. But you may, again, not understand how strong they are. So this is a chart from 2004 called the World Development Chart. All the countries in the world are here. The size of the country, India, China, the United States, is based on its population. The color is the continent, Africa, Asia, Europe, and so on, okay? On this side is health as measured by under 5 mortality, the chance of a baby making it to their 5th birthday. Down here is wealth, with rich countries over here and poor countries here. In 2004, the poorest country in the world was Sierra Leone. They had just come out of a pretty devastating civil war. Right? At the time, the under 5 mortality in Sierra Leone was 300. That means for every 1,000 babies born alive, 300 of them would die before their 5th birthday. That's pretty staggering. Even more staggering when you look at the healthiest country in the world, which at that time was Sweden, where the under 5 mortality was about 3. So 100-fold different in the chance of a baby dying before their 5th birthday as defined by their economic status. All right? Again, you probably expected this. You may not have expected the relationship to be that strong. What you may not realize is that this relationship also exists in the United States. Okay? This is the relative risk of dying before the age of 65 based on your income. So if you're rich, you're over here. If you're poor, you're over here. A relative risk says whatever this chance is, we'll call it 1. All right? So a poor American today in our country, a poor American is 3 times more likely to die before the age of 65 than a rich American. Think about that for a second. In our country today, a poor American is 3 times. And it's not a stepwise relationship. It's quite remarkably linear, just like it is globally. This next slide, as I've said before, probably changed the way I think about health more than any other slide. It's an old slide. It's $1980. Don't worry about it. But it's got a really important message. And there's 2 things about this slide that boggle the mind. What it says is life expectancy at age 45. Okay? So by the time you're 45, how many more years are you going to live? White men, black men, white women, black women, based on income, poor, middle income, high income in $1980. Okay? So why do we say age 45? Because it takes away those things we associate with poverty, high infant mortality, the violence of youth, the dangers of living in a poor environment, okay? And it says you've already made it to 45, how many more years are you going to live? And there's 2 things about this slide that are really mind-boggling. The first is how, look at this, 7 to 8 years for men, and for women 3 to 4 years. You'll notice that there is still a racial disparity. There is still a difference between African Americans and white Americans, but it pales in comparison to the socioeconomic status. Poverty is a tremendous predictor of poor health in our country. And the second thing that boggles the mind about this slide is that most of you probably have the same reaction in seeing it that I did, which is you say, well, of course poor Americans aren't going to live as long as rich Americans. And then you go home and you start to think about that. You say, wait a minute. In our country today, there's a 3 to 8 year difference in life expectancy. Years of difference. This relationship between income and health is really remarkable. And it's important to us in Tennessee because we have a rate of children living in poverty. Almost 1/4 of our kids live in poverty, 10% worse than the national rate. If you look at the 3,100 counties in America, you see a remarkable range from 10% living in poverty to 1/3. And here's the 95 counties of Tennessee, where 80% of our counties fall in the bottom half. It's important for you to know, wherever you're from, what your local poverty rate is, because there's evidence to suggest that the gap between rich and poor in our country is actually widening and not narrowing. This is income in the United States from 1969 to 2009. The U.S. is divided into quintiles, fifths. Right? So the fifth wealthiest Americans are here, the fifth poorest Americans are here. Does that make sense? 1969, 79, 89, 99, 2009. Okay? So what we've seen in the United States since the mid-60s when the war on poverty began, the average income, and these are constant dollars, from the poorest quintile went up from 9.9 to about 11.5, an increase of about 15.5%. At the same time, the wealthiest Americans went up from 106 to 170, an increase of 61%. So the ratio of the top fifth to the bottom fifth has gone up about 50% in my lifetime. Now, I don't put this up here to make a political comment. I know there are people in the political spectrum talking about this, but I put it up to make a really important public health comment. And that is, what this means is that those parts of the country, like some parts of Tennessee, some parts of central Appalachia, those parts of the country with higher rates of poverty may in fact see a widening gap and not a narrowing gap. And if you believe, as I do, that poverty is tied to health, you begin to realize that if we want to improve health in Tennessee or in Appalachia, we have to engage in economic development. We have to change this trend, because if the gap is widening, we really can't hope to narrow the health gap if we don't narrow the economic gap. The only other one of these I want to talk to you about is education, only because some of you are actually pursuing that at this time. Only some. I talked to Dr. Calhoun. He actually told me which ones of you aren't. And, no. Okay. It's the reason to look at the education statistics is because they're mind-boggling also, okay? Here's life expectancy by the time you're 25, all right? So by the time you should have finished your basic education, comparing those with less than a high school education to those with college degree or more, all right? Almost 7 years for men. 5 years for women. Think about that. That's phenomenal. A male in the United States who's a high school dropout will live about 7 years less than a male who's a college graduate. Now, some of this is because of income, right? We've already shown that income is tied to health. We know that a college graduate in their lifetime will make $1.1 million more than a high school dropout. So if you have any friends that are thinking of dropping out of high school or dropping out of college, you can tell them, stay in, it's worth $1 million in 7 years. But if you think about it, I mean, just actually get your mind around this for a second. This is phenomenal. It's actually kind of scary. And the next one is even worse. It's the chance of a baby dying in the first year of life based on mom's educational status. Right? So this is for moms 25 and older. So we're not talking about those who don't have a high school degree because they're 14. All right? Infant mortality rate is cut in half. The chance of a baby dying in the first year of life is half for a mom who has a college degree compared to a mom who's a high school dropout. That just boggles the mind. This relationship between education and health is really important. And it makes a difference to us because in Tennessee, our rate of having adults with a college degree is about half of what the highest states have achieved. Here's ones with some college at all. And again, you can see that we fall well behind the nation. In this case, being low on the list is bad. You want to be higher. Again, 85% of our counties fall in the bottom half. And again, just as I showed you with economics, there's reason to believe that this gap is widening and not narrowing. Okay? They did an interesting study. They asked kids, bear with me on this one, kids who were high school sophomores in 1990, high school sophomores in 1990, how many had a college degree by the year 2000? And so how many navigated a 7-year educational journey in 10 years? Make sense? If the moms are professionals, mom and dad are professionals, 73% of them. Your kids are overwhelmingly likely to be successful academically. If their parents were high school dropouts, less than 6%, a 12-fold difference. What that means is those parts of the country with lower rates of educational achievement may actually see a widening gap and not a narrowing gap. And if you believe, as I do, that education is related to health, you begin to realize that if you want to improve education, you want to improve health, you have to improve education in your community. We have to start thinking about health as something different than what we deliver through the healthcare delivery system. What we do is essential. What I did as a pediatrician, what you do as a pharmacist, what I do in public health is essential, but it cannot stand alone. We have to start thinking about health as the interrelationship of economics, education, health, and probably those other factors as well. So put it into words, what do we need to do to improve health in Tennessee? We need to work together to assure that everyone has access to affordable health care, including preventive services. Secondly, we need to work together to enhance economic opportunity and reduce poverty. And third, we need to work together to improve educational achievement. And what these all have in common, of course, is we need to work together. Right? These are not problems for Washington or Nashville or Johnson City to solve on their own. These are not problems for politicians, business leaders, physicians, or pharmacists to solve on their own. These are not problems for Republicans or Democrats, libertarians, Tea Party, socio-anarchists. These are things, if we don't address them together, we cannot solve them. Now, when I say this, health professionals typically have one of two reactions, or both. One is, when is class going to be over? The first is, well, it's not really my job. I mean, that's good. You've convinced me that education is important and economic development is important, but I'm a pharmacist. I'm a pediatrician. I teach public health. Or every one of you recognizes that a key part of your job as a health professional is advocating for your patients, the people that you serve. If someone comes into your pharmacy and asks for something that's not in their best interest, you have an ethical, professional obligation to say that. We are all advocates for the people that we serve. So whether I'm a dean of a college of public health, or whether I'm working for an international NGO, whether I'm working for a local health department, my job has been the same my entire professional career. It is your job. Your job is to assure that the people who come into your pharmacy, into your hospital, into your place of work are as healthy as they can be. And advocacy is an important part of that. There's nothing politically negative about advocacy. All right, it's part of what we have to do. The second obligation people have is usually stronger, and that is, yeah, but trying to change the health of the American people is too big a challenge. 300 million people, was it 50 million smokers? I mean, come on, how are we going to change that? But you remember I showed you this picture before? Some of you were awake at that point. I didn't really care that you knew what the causes of death in Richmond, Virginia 100 years ago were. I showed you that slide because I want to introduce you to this guy. This guy was a physician, born in the 1850s, trained at the University of Virginia, went out, joined the Army as a physician, went out to the Indian Wars, came back, became a public health professional, Albemarle County Health Director, Charlottesville City Health Director, excuse me, that became Albemarle County later. For those of you considering a career in public service, let this be fair warning. So why do I want you to know about this guy? Because back in this day, the diseases he was facing, remember, there were no antibiotics, there were only 2 vaccines in the whole world, and they weren't for any of those diseases. There were no magic bullets. These guys could easily have looked at this list and thrown up their hands and said, trying to change the health of the American people is too great a challenge. And yet this guy and other women and men, nurses, doctors, pharmacists, health professionals, did something really remarkable. They changed life expectancy in the United States by decades, most of it in the first half, in the era before what we consider modern medicine. All right? In the era before widespread use of antibiotics, in the era before the widespread availability of vaccines, they made a fundamental change in the health of the American people. Now, why do I want you to know about this guy? All right? Turns out he's not famous. There's nothing named for him. But he was my great-grandfather. And I often wondered, what would it be like to work at a time when you might reasonably say, these challenges are too great? Well, there's another picture in the Virginia Health Bulletin from 100 years ago that I think says more about what we need to do in Tennessee and in America today than any textbook that I own. And this is the picture. 100 years ago, Here are the hounds of diphtheria, scarlet fever, measles, whooping cough, the leading causes of death of that time. On the other side of the wall are the rather oddly dressed children of that time. They didn't throw their hands up and say there's nothing we can do. They said we can protect them by public education, by careful physicians, efficient health officers. They didn't throw their hands up. They said, how high is the wall in your town? Right? Well, today the leading causes of death have changed, right? Heart disease, cancer, stroke, chronic obstructive pulmonary disease. Those of you that know there's still no magic bullets. These are still really tough diseases. These aren't things that someone can walk into your pharmacy or into my clinic and be cured of. But we can be just as optimistic that if we build a wall, we can protect our children to the same extent they did 100 years ago. Today, perhaps the wall will be called prevention, access to affordable health care, improvements in education, economic development. But we can be just as optimistic that if we actually figure out a way of working together across professions, across political parties, even across states and countries, we can actually make a difference in the lives of the children of this country and the world. And if we do that, every place in our country will benefit, every state will benefit, but probably nowhere will benefit more than we will in Tennessee. I've introduced you to my great-grandfather. That's my son, Kevin. That's my son, Gregory, my daughter, Andrea, Kathleen. That's my wife. That's me. And I end with this slide to remind you. I told you not to take notes because nothing that I've talked about has anything to do with statistics. Okay? What I'm talking about is the future of our country. Do we care enough to make the difficult decisions to hand our children a state that is as healthy as it is beautiful? How do you perceive health? Take 2 flower pots. Put into one good, rich, nutrient soil. Put into the other rocky, unhealthy, unnutrient soil. Take 10 healthy seeds, put half into each pot. Water them and care for them. And what's likely to happen is we'll see different outcomes. This is, of course, a metaphor for the health challenges that people in our country face, in our state, and around the world. And the question isn't, well, the question can be whether we feel we have any obligation to other people or not. You can choose that we do, you can choose that we do not. But the one thing you can't conclude is that those of us who are most fortunate are here because of our own doing alone. There is a social obligation, I think, that we all inherit as being health professionals. It sounds trite, it sounds simplistic, but I think it is an essence of who we are as health professionals. And if you don't execute it, I think you're failing yourselves and you're failing your profession. Having on that happy note, I'll be happy to answer any questions.